Hi, everyone. Welcome to the Mental Health Awareness for the Birth to 5 Workforce Training. At the end of this training, we hope you will be able to define infant and early childhood mental health, recognize common mental health concerns of young children ages 0 to 5, identify the effects of early childhood adversity on young children's mental health and development, and identify the ways you can promote the mental health of young children. First, though, we'll ask you to take a pre-survey so that we can measure your change in knowledge pre and post the webinar. So if you will pause the video, scan this QR code, and the QR code will take you to a link that there will be a pre-survey there. There will be a post-survey then at the end of the webinar. So again, if you will pause the webinar, take a picture of this QR code to access the pre-survey link, complete the questions at this pre-survey link, and then resume the record. Okay, well, we are very interested in knowing who is here, and we fortunately will be able to gather that information from the survey that you just completed. And every single one of these individuals here has a role to play in infant and early childhood mental health. Home visitors, early interventionists, early childhood educators, therapists, family members, faith-based leaders, and friends and neighbors. Everyone contributes to the development of a young child. So what is infant and early childhood mental health? So if we look at this definition here, this is from the 0 to 3 Technical Assistance Center. And I'll ask as I'm reading this for you to refer to your activity packet to number 1 and complete the sentences in number 1 in your activity packet. So infant and early childhood mental health is the developing capacity of a child from birth to 5 to experience and manage and express a full range of emotions, form close and secure adult and peer relationships, and explore the environment and learn, all in the context of a caring environment and inclusive family, community, and culture. On this next slide are 2 different definitions of infant and early childhood mental health. The first one that you just heard, which is on the right, and then the second one on the left is from the World Association for Infant Mental Health. And it notes that IECMH, another way to say infant and early childhood mental health, is the ability of children to develop physically, cognitively, and socially in a manner that allows them to master the primary emotional tasks of early childhood without serious disruption caused by harmful life events. Because infants grow in the context of nurturing environments, infant mental health involves the psychological balance of the infant family system. So if you see in both of these definitions, I highlighted the most important components of infant and early childhood mental health. First, that IECMH is concerned with building social emotional competence in young children. And second, the field recognizes that infant and early childhood mental health is built through child caregiver interactions in a healthy family environment. So that context of infant and early childhood mental health is critical. When we think about the mental health of older children or adults, we often think about the dyad, we think about the concerns that one individual is having. So we can think about the concerns that the adult is having or the concern that the teenager is having. When we're thinking about infant and early childhood mental health, we're looking at the concerns that are occurring within the dyad, the child caregiver relationship, because we know that young children cannot exist without their family members or their primary caregiver, whoever that may be. And so when we're looking at infant and early childhood mental health, we're looking more at they're thinking more about these pictures here where there are we've got the family unit here, the primary caregivers. We're not looking at this third picture here where a child is sitting on a couch and receiving therapy from a traditional therapist. So again, when we're talking about infant and early childhood mental health, we're really looking at the importance of the dyad. So any professional who's going to be working with young children and their family should approach their work with a mental health lens. And so whether you're an occupational therapist, an early childhood educator, a home visitor, whatever your discipline and area of expertise is, everything that you do with the child really needs to support building a strong relationship between the parent and the caregiver. The caregiver and the child. So again, as it says here, the dyadic relationship not the individual parent or the individual child is the center of focus within infant mental health services. So this is different than other helping professions where the client's the individual. So you're going to be, if you're working with young children and their families, and you're going to be looking at like, how are they responding to stress together? How are they regulating together? Is the adult able to model positive stress response and emotional regulation for the child? And if not, if there are problems within that emotional relationship, then that's where the focus of the therapy and treatment is. So why is it important to learn about infant and early childhood mental health? Well, infant and early childhood are the most critical periods for growth and learning. And according to 0 to 3, when an infant or young child's emotional health deteriorates significantly, they can and do experience mental health problems. So we know that brain development is so rapid and so impactful in the early years. And so we need to do what we can to ensure that children have secure relationships and modeling of positive emotional regulation and stress response as their brains are developing. Okay, so let's think about some early childhood disorders that we might hear about. So if you go to your activity packet, number 2, list 3 emotional behavioral disorders that you think could be diagnosed in children between the ages of 0 to 5. So you can spend just a few minutes writing those down and then resume the recording when you're done. Okay, welcome back. So here are some examples of early childhood disorders. So for example, anxiety disorders such as separation anxiety disorder, selective mutism, behavior disorders such as ADHD or attention deficit hyperactivity disorder, depression such as depressive disorder of early childhood, and developmental disorders such as autism spectrum disorders. So here's some prevalence data from the National Survey of Children's Health that looks at the prevalence of these disorders in children ages 3 to 5. So 2% of all kids that age range have been diagnosed with ADHD, about 1.5% with anxiety disorders, about almost 4% with behavioral conduct problems, and then less than 1% with depression. So here's some more data. 1 in 6 children ages 2 to 6 years old, about 17.4%, has a diagnosed mental health or mental behavioral or developmental disorder. And we know that these disorders can lead to challenging behaviors in the classroom. That's how children often communicate that they're struggling. And we see very high preschool, pre-K suspension and expulsion rates because of these challenging behaviors and these early mental health concerns that have unmet needs. So children have unmet needs because of the mental health concerns. So when we look at how we think about the way children develop, we often organize their development into different developmental domains. And if you work with young children, you know this because oftentimes your screenings and your assessments and your curriculum are all organized around these domains. It's very helpful to think about these domains holistically, and 2, the importance of social and emotional competence in influencing all of the other domains. So if the physical and vice versa. So there's a kind of two-way relationship between development, the other domains, and social emotional development, and social emotional development, and the other developmental domains. So if a child is struggling with gross motor skills, that may impact their ability to form relationships. If they're struggling with communication, that may impact their ability to form relationships, and so on. So there are some really great resources out there that organize our milestones by age. And here are some examples from Head Start, and this organizes developmental milestones according to those that we would see in the infant toddler age and then in the preschool age. In this next video that I'm going to show you presents some really great prompts and descriptions of or questions that we can ask ourselves or encourage parents to ask themselves about their child's social emotional development. So it does, again, good job at providing kind of a different way to think about how to monitor our child's social emotional development. So we will watch that video now.
Hi, I'm Dr. Steve Slosman. I'm a child psychiatrist and a consultant with the New York State Project Teach program. I want to take a minute to talk with you about some of the changes you may want to look out for when it comes to your child's mental health, specifically if your child is between the ages of 0 to 5. It's important to utilize your child's pediatrician for mental health concerns, as well as other kinds of illnesses. Remember, you know your child best, but your doctor knows how to recognize an emerging problem. In other words, you might not be sure if there's a problem, and that's what your doctor is there for. Your concerns as a parent will obviously change as your child grows, but right now I'd like to share some questions to think about if your child is under 5. During these beginning years, your child is mastering all the things most of us take for granted: sleeping well, eating appropriately, relating to others, using words and being able to tell stories. These are the ways humans interact. And amazingly, we master these tasks in the first 5 years of life. Because of this, try to focus on the really basic things. Look at sleeping, eating, talking, and playing. Remember, these are only rough guidelines. Shape your thoughts based on what you know about your child's unique needs. For sleep, ask yourself, does your child sleep through the night? If not, how often does he or she wake up? How long does it take your child to fall asleep or to fall back asleep? Does your child have nightmares? Does your child remember the nightmares the next morning? Remember, very young children, and certainly infants, won't know how to describe a nightmare. Some children will even have a hard time knowing that an unhappy dream isn't real. Think about whether your child wakes up in the middle of the night feeling extremely frightened or sad. If this happens often, does your child appear to remember these events the next morning? Does your child ever wet or soil the bed? If so, how often? When does this happen? What is your nighttime routine? Does it vary? For eating, keep these questions in mind. When does your child eat meals? When does your child snack? What does your child eat at meals and at snacks? Is your child a picky eater? What are some favorite foods? For speech, decide. Is your child a big talker? Have there been changes in your child's vocabulary? Can you understand what your child is saying? Does your child tell stories? Can your child understand what you're saying? Will he or she listen to your stories and ask questions about them? Can your child follow instructions? How many steps of instructions can your child follow? For play, watch your child and consider, how does your child play? Do they play with friends or next to friends? Does your child have a best friend? Does your child have a group of friends? Does your child have an imaginary friend? Does your child draw? If so, what does your child draw? Does your teacher or child care provider have any concerns about your child? Does your teacher worry about your child's ability to pay attention? And finally, for family and family changes, ask yourself, is there any chronic family stress, or has a significant life event taken place within your home that may affect your child's well-being? For example, separation or divorce, moving to a new home or community, the birth of a child with special needs, or a serious medical diagnosis in the family. Make sure to let your child's pediatrician know if these or other significant changes are occurring in your family. Remember, there's no wrong answer to these questions and no answer that guarantees there's a problem. But if your answers make you think, look at your thoughts as an opportunity to ask more questions, and definitely involve your doctor in these discussions. To find more information about what social and emotional developmental milestones children reach at this age, take a look at the Guide for Parents of 1 to 5-year-olds. It's a brochure on the Project Teach website.
Okay, so here's the brochure that he was referencing, or a snapshot of the brochure, and it's a really great free resource. You can search for Office of Mental Health New York 1 to 5 years brochure, and there's just a lot of great details about kind of developmental milestones related to social emotional competence in young children. So when we're working with young children, we want to be able to determine what's typical and atypical behavior. Oftentimes, we get those confused in early childhood because sometimes the behaviors that are typical for young children to engage in seem a little concerning. But it's going to be important to monitor when a child is either lagging behind or jumping ahead of typical peers, or we see a significant change in their behavior or significant regression. So we can identify when there might be a sign or a symptom of a mental health concern. So when we think about signs and symptoms of mental health concerns in adults, these are some of the behaviors that we think about. So feeling sad or down, being confused, excessive fears, withdrawing from friends, maybe taking up some alcohol or substance use, changes in eating habits, and so on. So I want us to think about what are some of the behaviors that may be suggestive of mental health concerns in young children. So if you'll go to your activity packet number 3 and fill in the box there, the tables there, and list some signs and symptoms of mental health concerns for infants and toddlers ages 0 to 2, and also 3 to 5. And then you can resume the recording after you filled in number 3 in your activity packet. Okay, welcome back. So here are some behaviors that may be suggestive of a mental health concern in young children. So in infants and toddlers, we may see chronic eating or sleeping difficulties, inability to adapt to new situations. Children may be easily startled. They may have difficulty establishing relationships with other kids or adults. And then when we get into the preschool age, we might see some compulsive behaviors, just very wild tantrums, or kids being very withdrawn after being previously social, or loss of earlier developmental milestones. And so we want to, again, kind of pay attention to what's typical at each age range. What are typical behaviors? What are typical milestones? And then note when we're seeing differences in those typical milestones. Make sure that the differences aren't due to the child's personalities. So we're going to have kids who are very shy and quiet, just like we have adults who are very shy and quiet. But was the child previously social? And is that a big difference in their what their personality had presented like before? And then also make sure that the behaviors that we're feeling are atypical are not culturally appropriate behaviors. So certainly, there are different expectations for behaviors across cultures, and in some cultures, there are going to be behaviors that are appropriate and that aren't appropriate in other cultures. And so, so if we've ruled out the behaviors being suggestive of cultural differences or personality traits, then we might be identifying an atypical behavior that may warrant follow-up. So here are some examples of where, a typical behavior can become atypical when it's kind of at one extreme or the other. So if we've got a baby who's crying when their caregiver leaves the room, but stops once they hear their caregiver's voice returning to the room, that's pretty typical infant behavior. But crying behavior that may be suggestive of a mental health concern may be constant crying with little ability to be consoled by the caregiver. Then when looking at the toddler age, if we have a child who's afraid when meeting strangers, but warms up when getting to know them, this behavior may become atypical if the child has an inability to establish relationships with other children or adults. And then finally, looking at preschool age, may have kids who play well with others. That's very typical. But if we have a child who's withdrawn or shows little interest in social interaction, they may be suggestive of atypical behavior. So now let's go on to the next slide. And if you'll go to your activity packet, items 4 and 5, and note there, well, first with number 4, complete the table by matching the early childhood developmental domain with its appropriate definition. And then next, organize the signs and symptoms into the appropriate developmental domain. So note whether the behaviors that are on this slide are aligned with one developmental domain versus the other. And then after you have completed that, go ahead and resume the recording. Okay, welcome back. So I hope that with number 5 that you indicated that really all of the developmental domains are related to all of these signs and symptoms. So when we're thinking about children's behaviors more and development more holistically, we see that any sign or symptom of mental health concern can really have an impact on all the developmental domains we discussed earlier. So now if you'll go to your activity packet and complete item number 6, think of a child with a mental health concern. What are some risk and protective factors that may influence their mental health concern? So in number 6 in your activity packet, go ahead and list 3 protective factors and 3 risk factors that influence infant and young children's mental health. After you've done that, go ahead and resume the recording. Okay, welcome back. So here are some examples of protective factors and risk factors. So a protective factor can be defined as a characteristic at the biological, psychological, family, or community level that reduces the risk and promotes the health and well-being of children and families. And on the other hand, risk factors can be defined as characteristics that increase a family's chances for poor outcomes, including child abuse and neglect. And so the presence or absence of protective and risk factors can contribute to the mental health of infants and young children. So we've got here some examples of protective factors, so secure primary attachment relationship, social connections, supports for families, and then we've also got risk factors, so insecure primary attachment relationships, adverse childhood experiences, poverty, limited parental social supports. So in your activity packet, once you go to number 7 and answer this question, which factor do you think is most influential in determining the mental health of young children? And after you've completed that, go ahead and resume the recording and we'll look at the answer. Okay, welcome back. So hopefully you noted that the child caregiver attachment is the most influential variable for infant and early childhood mental health. So even when there are all sorts of risk factors that children are exposed to, if they have got that strong relationship with a primary caregiver, they tend to emerge more resilient than if they didn't. Okay, so we're going to talk now about a few of the characteristics of early development that influence infant and early childhood mental health. So temperament is one of these. And so temperament is the way that a child approaches his or her environment. The common way that we hear temperament is categorized is using these 3 categories. So easy, difficult, or slow to warm. And easy infants are thought to be adaptable, enjoy social interactions, enjoy new experiences. And then difficult infants are thought to be more irregular in their mood and very sensitive to changes in their environment. And then slow to warm infants adapt slowly to new situations and may withdraw from interaction. So the opportunities for social emotional engagement and then therefore social emotional development can be influenced by differences in child caregiver temperament or just by simply a child having a temperament that invites strong relationships with caregivers. And then when we look at attachment, attachment is referred to the quality or refers to the quality of the relationship that young children develop with their caregivers. And so this can be influenced by a match between a child and caregiver, adult caregiver, and other variables, including stress and parental depression, which we'll discuss a little bit later. And so in healthy attachment relationships, the caregiver recognizes the unique characteristics of the child, and the child understands that the caregiver is someone they can turn to for comfort when stressed or frightened, who's going to help them manage their feelings. So attachment relationships are formed very early on. So when attachment theory is one of the most popular theories related to parenting in that early childhood development, and a few of the important theorists for attachment theory were John Bowlby and Mary Ainsworth, and attachment theory explores the development of the personality and young child's capacity to form close relationships. So there are different attachment styles, and you'll see these described sometimes using slightly different terms, but here are four of the ways to describe the types of infant parent attachment. So secure, avoidant insecure, resistant or anxious insecure, and then disorganized insecure. And so the quality of attachment is mostly determined by the parent's response to the child, but certainly can be influenced by the child's developmental delays, child physical health concerns, or other genetic issues with the child. So with secure attachment, when the caregiver consistently responds to a baby or young child in distress in sensitive and loving ways, this can help foster secure attachment between the child and the caregiver. And this can include picking them up promptly and reassuring them. And so children with secure attachment styles often form strong, secure attachments throughout their life since they've learned to form healthy, trusting bonds early on. They may show more confidence in school, which can lead to stronger school performance and successful relationship building with teachers and peers. When we look at another attachment style, when caregivers aren't as emotionally available, children may develop an avoidant or dismissive attachment style. And so children with this attachment style are typically not distressed when separated from their primary caregiver and may engage with strangers in a similar fashion to their caregivers. And then if we look at the insecure attachment or resistant attachment style, this can be caused by inconsistent parenting. So inconsistent behaviors by a parent or caregiver can cause a child to become confused and insecure since they don't know what behavior to expect. So consistently not picking up or consoling a child may lead to the development of anxious attachment toward the caregiver. So this attachment style can create an overdependency of the child on their caregiver, leading to a clingy child. So these children, again, may display behaviors such as overly clinging to their caregivers. And then finally, insecure, disorganized attachment style. This can be a strong predictor for some challenging outcomes. So a child can develop a disorganized attachment when they have not received consistent care or have been abused or neglected. So why is attachment theory important? So attachment really forms the foundation that the child's going to use to interact with others. And so the having a secure versus insecure attachment at an early age can either create a positive or negative path for childhood development that can impact the way the child forms relationships throughout their life. So there are a couple of attachment disorders that there can be diagnosable by the ICD-10 or the DSM-5. So reactive attachment disorder and disinhibited social engagement disorder. Both these attachment disorders are really rare and are usually diagnosed between the ages of 9 months and 5 years old. And the assessment of these disorders really needs to be carried out by a trained clinician, not by the lay person. So children with attachment disorders may have less of a capacity to form and maintain healthy relationships. So when we look at reactive attachment disorder, this is characterized as a child's persistent lack of care seeking or attachment behavior toward their caregiver, even when they're alarmed or in distress. So an example of this may be a child who doesn't seek help from a caregiver when they're in obvious pain. So this is often experienced or seen in younger children who experience severe neglect. Again, it's not terribly common. Then there's this inhibited social engagement disorder. These children show high and inappropriate friendliness to unfamiliar adults. They may lack kind of that hesitancy or wariness to strangers and may tend to wander off and trust strangers. These children often lack social, verbal, and physical boundaries and may try to interact with adult strangers in an appropriate way that may come off as intrusive. This disorder is also rare. So some of the causes of attachment disorders are certainly there's genetics, disabilities, developmental delays, and then there are factors related to the caregiver's challenges. So maybe a presence of an unavailable parent due to depression, illness, or substance use, abuse and neglect, these are kind of the two causes of attachment disorders. Maybe if a child is in frequent foster care placements, or they've had a death of a parent, or imprisonment of a caregiver, then that just changes their ability to form those early, healthy, secure attachment relationships. Okay, so now if you will go to your activity packet and complete numbers 8 through 11, these questions are all related to the attachment theory information that we just covered in the slide. And so when you are done completing these, go ahead and resume your recording and we'll continue moving forward. Okay, welcome back. So here are a couple of other variables that can influence infant and early childhood mental health. So parental and situational stress and caregiver depression. So when we think about stress, parents can experience stress for a range of reasons: financial stress, relationship stress, lack of sleep, job stress, poverty, addiction, being a caregiver for parenting children simultaneously. And parenting stress can really negatively affect relationships within the family, including the parent-child interactions. We've seen that parenting stress is associated with parenting behaviors that are less supportive and more punitive in nature. And these negative effects of stress can be seen across all family types. So high income, low income, different ages of children, single, two-parent households, all sorts of family makeups. And one aspect of infant and early childhood mental health supports is to identify and reduce the parent stress so that the parent stress doesn't have a long-term negative impact on the child's social emotional development. So then when we look at the next variable, maternal depression, there's a strong relationship between maternal depression. And I'll go back and forth between maternal depression and caregiver depression, because we know now that the mothers are not the only primary caregivers, and depression of the primary caregiver can have the same impact on young children that maternal depression can. But there's a strong relationship between that caregiver depression and poor social emotional development. So caregiver depression can impact attachment, cognitive, social, and emotional development, and result in long-term behavioral problems for kids. And up to 1 in 5 infants are exposed to maternal depression, either in the womb or in the early months after birth. So approaches to infant and early childhood mental health should pay attention to the maternal mental health or the mental health of the primary caregiver. So let's dive a little bit deeper into both stress and caregiver depression. First, we'll start by discussing stress. First we'll start by discussing stress. So childhood trauma is often what is the result of extreme parental stress, and it's characterized by witnessing or experiencing an event that poses a real or perceived threat to the life or well-being of a child or someone close to that child. And this type of situation can really overwhelm a child's ability to cope and may result in disorganized or agitated behavior such as fear or helplessness. And young children are at the highest risk for exposure to trauma and are most vulnerable to its adverse effects. So there are different ways that we can categorize trauma, acute, chronic, and complex. And acute is a single event that's limited in time. So for example, a serious accident or a painful medical treatment. So the event is extreme enough to threaten a person's social emotional security, but it's not chronic like the next type. So chronic trauma is a buildup of multiple traumatic events over time. So for example, the child might be in an accident and then a tornado happens and then the child's exposed to community violence. And then finally, we have complex trauma, which is characterized by repeated exposure to traumatic events that can be severe or prolonged. And so this can include psychological maltreatment, neglect, abuse. This type of trauma is often perpetrated by a primary caregiver who is supposed to be a safe and trusting adult for a child. So exposure to the traumatic events can cause the body's alarm system to be triggered. This can result in the release of stress hormones, which triggers a stress response. And that triggered response is the body's stress response system. And noticeable effects of the stress response system can include increased heart rate or tense muscles. And so when faced with a threat, our brain prepares our body for action by releasing stress hormones, like cortisol or adrenaline. And these chemicals activate the system you need to respond to the threat by fight, flight, or freeze. So then if we have a child who is consistently being exposed to stress, then they are their stress response system is consistently activated. So there's 3 ways that we organize our stress that children may experience, and really that we as adults experience as well. So the first is positive stress, and this is mild and moderate levels of stress. So these is brief in duration, and often really this positive stress is needed for healthy development. It's needed for understanding how to regulate our emotions and develop coping skills to deal with more significant stressful situations. So then the next type of stress is called tolerable stress. And this is a result of an exposure to a non-normative experience that may pose a greater threat or greater level of adversity compared to positive stress. So this may include death of a family member, parental divorce, experience a natural disaster. But when children have a positive, supportive, caring adult through these tolerable, stressful situations, then again, they're able to tolerate that stress and develop coping skills that they can use later in life. And then finally, toxic stress is the most dangerous type of stress response, and this occurs when a child experiences frequent or prolonged activation of their stress response system without that supportive adult and that protection of that supportive adult relationship. So examples of multiple stressors that can lead to toxic stress can include child abuse and neglect, or parental substance abuse, or parental mental illness. Okay, so let's go ahead and look at matching these different scenarios with the type of stress response it produces. So you can see that this first one, Chris is physically and emotionally abused by his father. That's a type of toxic stress, but that's going to lead to toxic stress. Johnny is nervous for his first day of preschool. That's typical stress, positive stress. We expect children to experience that stress. Next, 4-year-old Sarah is upset that she has to receive a shot at her doctor's visit. That's positive stress. Children, as long as they have a positive adult to model how to cope with that situation, that's good stress. The next one, Billy's family lost their home in Hurricane Katrina, are now rebuilding in a different state. That's more of a tolerable stress. It's more stressful than your typical stress, but with the supporting, love of a family or caregiver, they can get through that. And then finally, Shannon's mother drinks heavily daily, passes out, leaving Shannon to take care of herself, and that's going to lead to more toxic stress. So adverse childhood experiences, or ACEs, are traumatic events that occur during childhood and adolescence, specifically between the ages of 0 to 17. And these experiences can include physical, emotional, and sexual abuse, neglect, household dysfunction, and other traumatic events that you can see here on the slide. So there was a landmark study by Kaiser Permanente and Centers for Disease Control and Prevention that looked at the prevalence of ACEs, but more importantly, looked at the health outcomes of individuals who had experienced one or more ACEs. And what they found was that there was a significant relationship between experiencing many ACEs and having poor health outcomes later as an adult. So here are some data on the prevalence of ACEs, and ACEs are highly prevalent in the United States, with about 61% of adults surveyed in 25 states reporting at least one ACE before the age of 18, and nearly 1 in 6, or 15%, reporting 4 or more types of ACEs. So certainly certain groups are more at risk of experiencing multiple types of ACEs, but ACEs in general are quite prevalent across all populations. So then we look at the association of adverse childhood experiences with early onset chronic conditions, such as cardiovascular disease or chronic obstructive pulmonary disorder, cancer, depression, diabetes, etc. And findings really show a dose response relationship between ACE scores and negative health outcomes, which means the more ACEs that one has, the more significant the negative health outcomes are. Okay, so then if you'll go to your activity packet now and complete items 16 through 18, complete items 14 through 18. These are all related to stress and ACEs. These questions are all related to stress and ACEs. Okay, so now we're going to return to our discussion of caregiver depression. Specifically, we're going to talk about postpartum depression. So postpartum depression is characterized as having depression that occurs after having a baby. And so feelings of postpartum depression are more intense and last longer than those of baby blues, a term that's often used to explain or describe like worry, sadness, tiredness. And so postpartum depression is common and can have a significant impact on the mother-child relationship. So here are some prevalence data on related to postpartum depression. So in the US, about 1 in 8 women experience symptoms of postpartum depression. Teen mothers have the highest rate. And then certainly there are other risk factors for postpartum depression. So here are some of those risk factors. So depression during pregnancy may be the strongest predictor for later experiencing postpartum depression. Also, women with history of depression prior to conception may be at higher risk of postpartum depression. And then you see some other risk factors on the slide here. So postpartum depression can impact a mother's mood, energy, or stability. It also can influence an infant and early childhood mental well-being in several ways. So the most common of them are changes in behavioral inhibition and behavior, and maybe externalizing disorders, some challenging behaviors that a child may present with because of the impact of postpartum depression on them. Okay, so if you'll go now to your activity packet, items, I think, let's see. Yes, items 12 and 13. Okay, items 12 and 13, these items are related to postpartum depression. Okay, welcome back. Now let's look at brain development. So again, the primary need of a child in the early years is to form healthy and secure relationships. And there are 700 neural connections that are formed every second during the first few years of life. And these neural connections are formed based on a child's environment and experiences. And so it's critically important that we understand how trauma and early adversity can impact that brain development. So the brain develops from kind of simple lower regulatory systems such as the brainstem and midbrain to then the more complex, which has the cells and synapses. You can see here just kind of a very brief overview of the different systems in the brain. The brainstem develops first, and this handles very basic functions such as breathing and heart rate. Then the midbrain is focused on functions such as safety and responses to threat. Then the limbic system controls feelings and emotions, and then the cortex controls executive function. So if we look at the effects of trauma on brain development, neglect and trauma can affect the development of different regions of the brain. So children, their brainstem and midbrain may overdevelop. So children may have overdeveloped safety and stress responses, or they may act more impulsively. There may be disruptions to the limbic system, so that may impact their development of attachment, emotional reactivity, sexual behavior, learning and memory. And then finally, disruptions to cortex development that may impact the development of abstract thought and language. So again, social emotional factors can cause a child's experience of stress from trauma to be different from another child. So, trauma that one child experiences may not feel like trauma to another child. And so there are different contextual factors that can contribute to how a child reacts to traumatic events. So some factors include, differences in child's age when the trauma occurs, perception of danger, whether they're the victim or the witness, and then the presence and availability of adults who can provide help and protection, which is the most important variable for children when they've experienced trauma to predict resilience from that traumatic experience. Okay, then if you'll go back to your activity packet and complete item 19 related to the brain region and the different function of the brain region. And you can return and turn the recording on when you're done. Okay, welcome back. So now we're going to move into a discussion of resilience and what can we do to address early adversity. And so there's this new model that I'm not going to spend too much time discussing because it is very new and it's still being studied, but it's called the Protective and Compensatory Experiences, or the PACEs. And so what the researchers have done with their PACEs work is they have organized the resilience literature into the different variables that predict resilience. And they've organized the resilience factors by age. And so you can see the different resilience factors for ages 0 to 5, early childhood, nurturing care, play groups, safe and friendly child home, physical activity and play, daily routines and limit setting, amongst others. And so we want to take definitely a protective active approach to infant and early childhood mental health because a lot of our interventions focus on eliminating risk factors. And so that's good. It's good, but it can also emphasizing family risks can leave families feeling stigmatized or unjudged or not taking into consideration their strengths and the gifts that they have to help address early adversity. So the benefits again of the protective factors approach, it focuses on positive ways of engaging families. It helps identify areas where families and kids can grow. And it helps agencies build capacity to support families in collaboration with other organizations. And it helps young children and families build resilience and develop skills that can contribute to positive outcomes. So this is a model that you often hear about, the healthy outcomes from positive experiences, or the HOPE model. This is based on research that shows that positive childhood experiences promote child well-being and can create healthy, thriving adults, even when a child has experienced childhood trauma. So the 4 building blocks of the HOPE model are listed here on the slide: nurturing and supportive relationships within the family with other children and adults, safe, stable, equitable environments to live, learn, and play, social engagement and a sense of connectedness, and then social emotional competencies. And then it's important for us to think about resilience. Some children adapt remarkably well despite high levels of adversity, and this is called resilience. And so resilience really refers to individuals' ability to cope with adversity and bounce back from difficult situations. Resilience is the product of interacting biological, psychological, social, and cultural factors, and these factors can determine how a child responds to traumatic events. Okay, so then now let's think about what can your individuals in your profession do to promote infant and early childhood mental health and ensure that we have resilient children and families. So everyone who touches the life of a child can promote infant and early childhood mental health, and this can include home visitors, early childhood educators, families, early interventionists, public health professionals. Infant and early childhood mental health is a diverse, multidisciplinary field ranging across many professions, and professional workers need to share their expertise and resources and work collaboratively to most successfully enhance the mental health of young children and their caregivers. So now let's look at what different disciplines can do to support infant and early childhood mental health. And we'll start with home visitors. So early childhood home visiting programs have been shown to be an effective approach for providing prevention and early intervention services for at-risk populations. So families who enroll in home visiting programs often have sociodemographic factors associated with elevated risk for maybe less positive outcomes. And so here are some strategies that home visitors can use to promote positive infant and early childhood mental health despite the risk. So provide education and support to vulnerable families, link families to community services when needed, create a positive relationship with the families, and then receive training to ensure that what you're doing aligns with best practice. So here's a study that looked at the benefits of infant and early childhood mental health home visiting. So the Early Childhood Head Start Home based infant mental health study highlights the benefits of embedding infant and early childhood mental health services into early Head Start home visiting programs. And in this study, 152 low-income families were randomly assigned to receive either IECMH infused services, home visiting services, or other home visiting and related services. And so the home visitors providing the IECMH informed home visiting services were trained in IECMH, they received ongoing reflective supervision, and they focused their home visiting services on building healthy relationships between the family and the child. So the families began receiving services when their target child was 1, and they received these services until the target child was 3. And then their outcomes were assessed when the child was 5, and again at 7. And the results of the study suggested that the mothers and caregivers in the IECMH home visiting group reported healthier family functioning, better family relationships, better coping skills, and less stress than the families in the comparison group. And then we look at what early childhood educators can do to promote positive mental health. So more children are attending preschool than ever before, and they're getting the opportunity to get that early learning and development. And so social emotional learning is an important component of healthy development. And more and more schools are incorporating social emotional learning into their curriculum. That early childhood has always had a focus on social emotional learning, but what we can make sure that we're doing is setting clear expectations and acknowledge and praise positive behaviors in our classroom, provide emotional support to children, because we as early childhood educators are often having to step in as the primary caregiver, maybe experiencing stress. Then we can encourage parent involvement to streamline what's being learned in the classroom with what's being reinforced at home. So there's some great research showing that childcare can mitigate the impact of early life adversity. And so there was a study that looked at youth who had been placed in a high quality early childhood setting for their 5 years from 0 to 5, and it compared the long-term outcomes against youth who were not in high quality childcare settings from 0 to 5. And what they found is that the youth who were in high quality childcare settings from 0 to 5 had fewer depressive symptoms as an adult than did the adults who as children were not in high quality childcare. So childcare can mitigate the impact of early stressors. So then what can families do to promote positive infant and early childhood mental health? So we know that a child's relationship with the members of their family play a really critical role in healthy brain development. And families can provide structured and safe environment for infants and young children by establishing routines and behavioral expectations. Parenting skills and family relationship skills teach developmentally appropriate expectations for child's behavior. Nurturing relationships with parents and caregivers can help support then what type of relationship the families have with their children. So children can, begin learning at home long before they ever reach the classroom. So parents play a really critical role in supporting early childhood learning and school readiness. And there was a study that found that 93% of state-funded preschool programs reported one or more types of family engagement activities, such as opportunities for families to become involved in activities at school, parent conferences, some did home visiting, and that these home-based parenting practices can predict substantial growth in attention and language skills and reduction in problem behaviors during preschool. There were many studies that have shown that when parents are involved in their child's school at a very young age, that children are more likely to show growth in social and academic skills. So then what can public health professionals do to promote infant and early childhood mental health? So, there's a recognition that the increasing prevalence of ACEs, or really the high prevalence of ACEs along with increasing prevalence of ACEs, is a major public health concern. And public health approaches typically place prevention efforts at the forefront of the work that they do, and they work to create broad population level prevention and intervention strategies that can address the factors that lead to ACEs in the first place. So here are a couple of strategies listed here. So using epidemiological data to understand how ACEs prevent and promote mental health, propose policies, programs, and interventions that address the underlying causes of ACEs, and ensure supports are available to targeted populations. So many of our strategies that we use to address infant and early childhood mental health are organized around this public health model of prevention. And so we look at services and supports that are focused on prevention promotion for the entire population. We then look at what supports might be available for families or children who are considered at risk, so that those early intervention services. And then we look at what treatment is available for families and children who are experiencing concerns. So again, the primary public health goal is to prevent ACEs, and here are a couple of strategies that can be employed. So strengthening families and communities, promoting resilience, and addressing structural factors that contribute to childhood trauma. So strengthening families and communities involves providing support and resources to families to help them cope with stressors. And this can include parenting classes, financial assistance, and access to healthcare to ensure we're building strong communities. That can also help families by building a network of social support and reducing social isolation. So there are strengthening families and communities programs within states, and Georgia does have a strengthening families program within their state. So then we can look at how can we promote resilience. So we can look at building the coping mechanisms of young children. We can, engage in resilience building practices to empower young children by fostering a belief in their ability to overcome challenges, promote positive relationships among young children and their caregivers, because we know that that's the single most important factor in children emerging as resilient. And then finally, we can look at addressing the structural factors by creating environments that promote safety, stability, and nurturing relationships for children. Then addressing structural factors can focus on, again, preventing ACEs from occurring in the first place. And so it involves implementing policies and interventions that promote a safe and healthy environment for children. These can include efforts to reduce poverty, improve access to quality education, provide affordable housing, and ensure that there's access to healthcare and social services. So I mentioned policy development. So public health agencies are well positioned to collect and disseminate data, propose policies, and implement preventative measures, and then evaluate programs that can prevent ACEs from happening. And so we'll discuss three components of policy development, which include formulating evidence-based policies, mobilizing community partnerships, and the continuous improvement and adaptation. So here is some information about formulating evidence-based policies. So evidence-based policies really rely on rigorous research and data analysis to inform decision making. And so this approach makes sure that policies are based on reliable evidence rather than personal opinion. And so evidence-based policies are going to consider the risk and protective factors that are associated with ACEs. And so there's research that's identified various factors that contribute to ACEs, such as socioeconomic status, family dynamics, community support, and access to healthcare. And so by considering these factors, policymakers can develop targeted policies that aim to reduce the risk factors and enhance the protective factors. So we want to look at how to mobilize community partnerships so we can engage with experts and stakeholders to address and support or address and prevent the impact of adverse childhood experiences. So we want to identify key stakeholders who have a vested interest in ACEs, such as psychologists, social workers, educators, healthcare professionals, policymakers, community leaders, organizations working in child welfare, mental health, et cetera. And so all these stakeholders bring diverse perspectives and expertise to the table. We want to, again, work together to leverage each other's knowledge and networks to create a more comprehensive and impactful approach. And then finally, we want to look at continuous improvement and adaptation. So it's important to recognize that policy proposals may require refinement and adaptation over time. So participants who are engaged in this effort and stakeholders who are engaged in this effort should stay up to date with the latest research, make sure to evaluate the outcomes of implemented policies, and then be open to modifying their policies and proposals based on new evidence and feedback. So along with this, we want to make sure that we're helping families and children access appropriate services. So we want to make sure we know what the comprehensive array of activities and services is in our state, and ensure that families are connected to those services so that the services are being well used by all the families that need them. So there are various treatments for infant and early childhood mental health, so like clinical treatment. So here are two listed on this slide: child parent psychotherapy. This is again, both of these treatments focus on the dyad. And so child parent psychotherapy is most appropriate when there has been a traumatic event that's been experienced, and the attachment relationship or the relationship between the parent and the child has been impacted in some way. And so therapy then focuses on addressing that. Then there's parent-child interaction therapy, which is often used for children with social emotional behavioral disorders. And it's been proven to reduce stress and improve child behavior. Okay, so now if you will go to your activity packet and complete items 20 and 21. And these are focus on what you can do in your role to address infant and early childhood mental health. Resume the recording when you're done. Okay, welcome back. So then next we want to talk about taking care of yourself and self-care for the workforce. So taking care of yourself is very important. We want to recognize the signs and symptoms of stress in yourself in order to identify times when additional support or coping mechanisms may be needed. So we want to enhance your own resilience by making sure you're communicating with your coworkers, supervisors, and employees about job or personal related stress, and make sure you're finding healthy ways to cope with stress, such as mindfulness, exercising, or whatever you do to cope with stress. Workplace stress has been increasing for decades in the US, and compassion fatigue is often linked with burnout and compassion satisfaction within the healthcare field. And so because some of the signs of compassion fatigue can mimic or overlap with other issues, you may not realize you're experiencing compassion fatigue, and that's what's causing your distress. So it can be helpful to get some support to address you and your compassion fatigue because of all of the help and care and love you're giving to others. We know that our own stress can have an impact on the children and families that we work with. And this is an example of a study that looked at the relationship between teacher depression and punitive discipline responses. So again, it's not just maternal depression that can impact children's social emotional development. There was a study of 97 teachers in the Chicago area looking at the relationship between teacher depression and teacher requests for expulsion. So the study was conducted in private childcare settings, not affiliated with Head Start or the public school system. And there were some two really important results that rose from this study. First, teacher requests for expulsion were significantly positively related to teacher levels of depression. So in other words, the more depressed teachers were, the more likely they were to expel a child from a childcare center. But on the other hand, what they found was that the relationship between teacher depression and student expulsion was moderated by the center's use of mental health consultants. And what this means is that when centers receive consultation from a mental health professional, higher levels of teacher depression were not associated with an increase in teachers requesting that a student be expelled. So when centers did not report receiving consultation from a mental health professional, higher levels of teacher depression were associated with increased expulsion requests. So again, we want to make sure we're taking care of our adults so that our adults can best take care of our children. Okay, then if you'll go to your activity packet and complete the last item, item number 22, and answer this question. What can you do to find balance between supporting young children and their families and taking care of your own emotional and physical needs? And resume the recording when you're done filling in that item. Okay, welcome back. Okay, well, that concludes our session. If you'll hang on for the post survey, I just want to summarize what we discussed. Early identification and intervention for children who've experienced ACEs can help mitigate the negative effects and promote healthy development. There's a need to establish programs to build resilience during childhood, and then providing trauma-informed care. Make sure to educate yourself and others involved in the child's life about trauma-informed care. So thank you so much for participating today. And if you will go to the QR code, the link that is at the QR code on this slide, you can complete the post survey and let us know, how much you have learned by completing the quiz questions, and then also provide feedback on the training as a whole. So I'll leave this up for a few more seconds so you can make sure to take pictures of the QR code to get that link to that post survey. And I want to thank you again so much for taking the time to participate in this training today.